topic is going to be self-assessment measures. We're going to talk about the purpose, the different types of measures, and applying these. And remember, I just discussed choosing a self-assessment measure that you would if you were presenting this in your oral rehab session, but I want you to choose one and state that and why that you're going to that's appropriate for the population and the material that you're going to be discussing. So be thinking about that as I talk about self-assessment measures. So the purposes is we're going to talk about the purposes of measures. We're going to discuss several measurements that are typically used in the profession of audiology. Now remember, we've already talked about some self-assessments that are specific to hearing aids. So if you chose, for example, let's say you chose a group of veterans, right? Military personnel. So maybe if you, think about this scenario. If the population that interests you is veterans, you could say, I'm going to choose a group who are during the course of AR or who have just been fit with hearing aids. And you could do an assessment. Remember, we talked about the COSI, where they write what their priorities are, where their most difficulties are, and then rank those, and pre and post hearing aids. We could do the AFAB. So we talked about hearing aid assessments. So you could work with a group of participants and do pre and post hearing aid self-assessments. These are more self-assessments to rank perceived handicap or communication handicap, where this information's been taken in the acknowledgement slides. Okay, so first let's talk about the purposes of self-assessment measures, and unfortunately I'm going to read these to you. There are a number of self-assessment questionnaires available to audiologists. Each is a form of a case history interview in which the patient responds to a set of statements or questions pertaining to his or her communicative abilities, disabilities, perceptions, and or needs. So remember, self-assessment measure is an extension of a case history. We can ask a case history, and remember in earlier weeks I gave you a typical sample case history. It can ask about, do you have a history of ear infections, tinnitus, dizziness, but we're not asking about really, or we are only briefly in a typical case history like the one I showed you. We're not really getting at communicative abilities. Where are their areas of difficulty? What are their perceptions of how this disability or how this decrease in hearing is affecting their lifestyle, their relationships, their work? How do they feel others perceive them? Now, as a hearing impaired individual, how do they perceive themselves? And what are their needs and their priorities? A case history is only getting us some basic information. That's very helpful, but that's not self-assessment. This is the next step beyond. The focus and purpose of particular self-assessment tools differ, and the audiologist must select the questionnaire or scale that provides the clinical information that he or she is seeking. So what are you looking for? The uses for self-assessment measure include really a screening of disability or handicap, okay? An overall screening, and we'll talk about that. Does a problem exist or maybe not at this time? Okay. Also, a diagnostic interview and counseling is part of the self-assessment measures. Hold on a second. I'm trying to remember. The uses for self-assessment measures include, I see my train of thought. So screening, really, is there a problem or is not? The self-assessment can be used as we're trying to assess the information prior to diagnosing, prior to doing our testing. Maybe it will gear the audiologist to do more testing in noise, right? If that's the area of difficulty, although that tends to be, again, with most of our most of our patients with sensory neural hearing loss. It certainly can gear us in counseling, right? Rehabilitation, evaluation. So how a person perceives themselves is going to, and their abilities, their disabilities, is going to help us gear them to what they need as far as rehabilitation, towards amplification, towards assistive devices, to one-on-one AR, and within or group AR, oral rehabilitation. Should we focus on lip reading skills, or should we really focus more on communication skills? Or is it a matter of talking about communication styles and trying to motivate and move a person to a more passive style of just smiling and nodding and not asking questions like, could you rephrase that please, to a more assertive style, okay? Determination of benefit and satisfaction. That is, our self-assessment can be used to, as I just said, for determination of benefit or benefit or satisfaction. And that specifically would be the hearing aid related self-assessment. So again, the COSI or the AFAB saying, describe your communicative abilities pre-hearing aid, and then give the self-assessment measure again post, and look at benefit. We could do this to look at older hearing aids that they've utilized versus newer hearing aids. Maybe we went through we fit through one company, such as Phonak, and they did fair, and we took those hearing aids back and we refit them with a different company, which really would have a different sound quality, perhaps different because they utilize different algorithms, so different signal processing. So we could then give them, fit them with Oticon hearing aids, and we could do a determination of satisfaction between one or the other by utilizing a self-assessment measure versus saying to the patient, so how's it going? What do you think? Which one do you like better? That's important, but this is an actual measurement. We can give it repeatedly and use it for comparison purposes. We can use these for compensation. So if we're, oh gosh, how can I give an example for compensation? I don't know. I'm going to have to think about that. I'm trying to think of a good example that I could use for the purpose of this class. Also, acquisition of demographic and research data. Okay, that would be another good measurement to use. So completing data for research projects. Doing a self-assessment prior to AR sessions and post. What are the benefits or lack of benefits? Okay, so we can do these for counseling measures also, or for research measures to get information about different demographics and obtain that data. We're going to have to get back to the one on compensation. I have to think of an example. Okay, when we talk about the first one, screening of disabilities, I pulled this from the ASHA, the American Speech and Hearing Association. We will utilize the ASHA 1997 guidelines for audiological screening of adults to describe the way in which self-assessment measures are used for screening purposes. ASHA's audiological assessment panel recommends that adult screening addresses the identification of disorders, impairments, disability, and handicap. And ASHA has obviously have certain guidelines about screening and certain screening forms that can be completed quickly to say, is there a disorder, an impairment, a disability, or handicap, and we need to move on with testing and counseling and recommendations, etc., or not, and say not at this time. So let's talk about ASHA's definitions. A disorder, as defined by ASHA, is any anatomical abnormality or pathology. It may or may not result in a change in function of a given organ or organ system. So a disorder would be the dying of outer hair cells in the cochlea due to noise exposure, or as a result of aging or presbycusis, aging of the cochlea in the auditory system. Okay. The next definition is impairment. Impairment is going to be Impairment is any loss or abnormality of psychological or physiological function. So that would be the hearing impairment. What the mild to moderate loss or the hearing loss in high frequencies due to the aging of the auditory system. Okay, so it implies that some functional aspect of an organ or system or mechanism is outside the normal range. So again, describing a moderate, we can have first the damage in the cochlea, which really leads to the impairment, perhaps a mild to moderately severe sensory neural hearing loss. The impairment is the hearing impairment. It's outside of the range of normal. Disability. Remember, we touched on these with the WHO right at the beginning. I kind of glossed over the World Health Organization. So this is kind of really clarifying that that concept that I kind of introduced early on. Disability is any restriction or lack of ability to perform an activity by an individual. So the result of the impairment. This would be difficulty hearing and background noise. Okay, so this is the result that plays out from the impairment. Then the next step is the handicap. The difficulty experienced by an individual as a result of the impairment or disability as a function of barriers. So it could be difficulty in the work environment, difficulty with relationships, isolation. So that is the handicap, the difficulty experienced by an individual as a result of an impairment or disability and as a function of barriers. So communication, structure, architectural, attitudinal, lack of accommodations or lack of appropriate ancillary services required for effective communication. You can refer to the ASHA guidelines to familiarize yourself with the recommended clinical process of pass-fail criteria. So ASHA does have some guidelines of screening for disability. And there are some screening forms. You will note that the recommended protocol for the screening of disability is quite different from protocols for the screening of disorder and impairment, and that you could find if you decide for some reason to research the ASHA guidelines. Specifically, it's recommended that screening for disability be conducted with self-assessment instruments that are valid and reliable, and ASHA guidelines recommend two specifically. And these two specifically are Hearing Handicap Inventory, so the HHIE for elderly, and there's a screening version, and then also the SAC, Self-Assessment of Communication. And we're going to talk about these a little more. It's important to note that these particular measures are recommended as examples of appropriate screening instruments. Others may be used as long as they have been shown to be reliable, blah, blah, blah. Okay, both of these are really short, a few questions screening to assess, is there a disability or an impairment or a handicap or not? When would you utilize these? Okay, here's when you do. Screening for adults is difficult, right? So let's think about this. We do hearing screening for pediatrics, right? Hearing screenings in the schools, hearing screenings. Those of you as potential speech language pathology grads will have to get a certain amount of hours in hearing screening. Hearing screening for children, we have cutoffs and we can say pass or fail. Hearing screening for adults is much more complicated because let me say this. If you go into a senior center and you're going to do a hearing screening and your cutoff for normal is 20 dB across the frequency range. So let's say you're going to screen, pass or fail, they hear it or they don't hear it. You don't do an ascending, descending. You just, at 1000 hertz, you put the okay, let me back up. You put the headphones on the person, you set your audiometer at 1000 hertz, you set your decibel level to 20 dB, and you present beep, and they either raise their hand, they don't. Okay, let's say they don't. So that's a fail the screen at 1000. Then you go to 500. Beep. They don't. Fail the screen at 20 dB at 500, right? If that's going to be our cutoff for normal. We go to So we did 5, 1, and then it's usually 2 and 4, 2,000 hertz and 4,000 hertz. Same thing at 4,000. They don't raise a hand at 20 when you present at 20. At 2,000, same thing at 4,000. So we would say they failed the screen. Here's the problem with screening for adults, especially as we get into the senior population. They're all going to fail the screens, right? So I can't say that it's not worth being done, because that wouldn't be true. I think it's an idea to say this was a screening. I just screened for frequencies at the range of normal and you didn't respond. So I recommend a full audiological evaluation. Okay? Here's the problem. It's just misinterpreted with adults. It tends to be misinterpreted all over the board. I'm deaf, I didn't pass, I'm deaf, I failed, I have no hearing. I mean, it just gets so misinterpreted. Or let's say they pass at 500 and 1,000, but fail at 2,000 and 4,000. Then what do we say about it? Again, we have to say you failed at 2 frequencies, which sometimes is hard for them to understand, and you need a full evaluation. Okay, so screening for hearing with adults is iffy. But we also, so oftentimes, as audiologists, we go into senior centers and we do a hearing screening and a hearing an HHIE, a hearing handicap inventory for the elderly, a screening version that's really going to assess, do they feel they have a handicap or disability or not? We kind of add these up and then counsel them with both information. Well, we did a hearing screening in both ears and you didn't pass in either. And by your answers, it's suggesting that you are having some issues with communication due to hearing. We recommend a full audiological evaluation and follow-up counseling. So that's really what a screening tool for adults would entail. Here's the sample. I scanned in a sample so that you could see it. And again, you may be thinking about what you would choose and why that you would present or you would want to have your participants complete. So this is a hearing, the HHIE for seniors. Please check yes or no, or sometimes in response to each of the following items. Do not skip a question. Because we add them up. So the questions are, and they're focused in different areas. One is going to be related to emotions, one related to social. I'm sorry, so 2 different categories. Does a hearing problem cause you to feel embarrassed when you meet new people? Okay. Does a hearing problem cause you to feel frustrated? So here's embarrassment and frustrated. Those are on the emotional side. Here's the social side. Do you have difficulty hearing when someone speaks in a whisper? Yes or no? Let's look at another social one. Does a hearing problem cause you difficulty when visiting friends, family, or so they're going to complete it. It can be completed in a few moments. Of course, we want to make sure the patient understands, they're able to see the evaluation, or you can help them with that. They're English speaking or you have a translator. So those issues we have to clarify. And then we have a raw score, a rating of handicap. So for example, if we have a raw score of 0 to 8, that would be no handicap, 10 to 24, mild to moderate, 26 to 40, a severe. And then we would counsel in this, really saying things like, it certainly shows that there's some communication issues, and that compared with your hearing screening, we highly recommend blah, blah, blah. Okay? So this is a self-assessment, a screening tool. Why it's a screening is because it's very short. It's short, it's quick, it's easy to complete, and it gives us valuable information. We could implement this in any setting. You could use this in an AR setting. We could use this in an office setting on every patient who comes in who's concerned with hearing loss. If we don't in the clinic that I'm at part-time, but if a patient completed this and I saw this when they came in, that would be very valuable to me. And also, think of it this way, wouldn't it be valuable to the patient to ask these kind of questions to really assess and delve into where the issues may be? Maybe that would give them a better sense of, we're looking at the whole picture, right, of what's really going on, perhaps not just trying to sell them hearing aids, which once you turn 65, you're bombarded with that information in the mail. So also, for those reasons, it could be very helpful. This one is an example of the HHIA. This is for, an S is for the screening version. The difference is the previous one is based on is geared for the elderly versus adults. The difference is the one that's for adults versus the elderly is more geared for more active environments, and particularly the workplace. Although this makes some assumptions that perhaps elderly people are in more quiet, sedentary settings, where we have to note that that's not always the case. We have to be careful of that. So again, this is a screening version for adults versus elderly. But then if you have a very active elderly adult, then this would be appropriate. Again, it's looking at their perceived handicap from an emotional level and a social level. This one is a self-assessment of communication, also called the SAC. This one is asking various communication situations, and they're going to rank from 1 being almost never or never to 5, practically always or always. So let's look at 1. Do you experience communication difficulties in situations when speaking with one other person? For example, at home, at work, in social situations with a waitress, blah, blah. The second one, do you experience communication difficulties in situation with conversing with small groups? Next one is with a large group. In various types of entertainment. Do you experience difficulties when you're in unfavorable listening environment, like a party or background noise? Do you experience communication difficulty when using or listening to various communication devices like the telephone, warning signals, alarm, those kinds of things? Then the second portion is feeling about communication. Do you feel that any difficulty? Does any problem or difficulty with your hearing upset you? And then other people. So it's looking at these also, again, communication aspects, feelings about communication, and social aspects. This would also, this of course is a screening tool. So by screening, it's quick, right? 10 questions. It could maybe take 10, 15 minutes, if that. For other individuals, maybe even quicker, to kind of get an overview of their communication situations and how they feel about hearing loss or their struggles. This could also gear you as an audiologist of what direction to go to. What is the main issue here? We're identifying the main issues. So those are screening tools. Summary slides of upcoming information. We're going to talk about one other screening tool. It's a significant other assessment. So it's like the SAC that we just talked about, but for the significant other to complete. When we talk about the next group, intermediate length and diagnostic self-assessment tools, these are going to be longer scales. So these are no longer screeners. They're self-assessment tools or scales. This is a scanned-in example of the significant other assessment of communication. So again, like the SAC, but for significant others to fill out, right? A spouse, significant other, a family member, a daughter, a son, a child of the individual. So let's look at a couple. They're going to focus on different categories. Disability, disability with various communication situations, feelings about communications, and other people. So the same categories, but let's look at the difference of how the questions are stated. Does he/she experience communication difficulties in situations when speaking with one or others? Does he/she... So if you look at each one, I don't want to read through each one, but you're going to see the pattern. Let's look at these ones. Do you feel that any difficulty with his or her hearing limits or hampers her personal or social life? Does any problem or difficulty with his or her hearing visibly upset them? Do others suggest he or she has a hearing problem? So you're kind of getting the feel of it, right? It's the same questions essentially, but from the point of the significant other, right? Very interesting. So, one thing that we've done in the past that you may want to do, and again, you can do a screening form versus a full assessment. This may interest you. Also, these work very well in oral rehabilitation sessions when we do them because they're quick, so it doesn't take up a lot of time. To give the SAC, the other one that we talked to, the SAC to the participant, the person who is there for the hearing loss, and then the SOAC to the significant other. And then we can talk about these, we can look at them, we can combine them, right? As an audiologist in clinic, this was very effective for me to look at, to see, are they on the same page? Are there very differing feelings or perspectives on the individual and their communication ability, or how upset they give? Certainly gives us areas to focus on with counseling, right? Very, very useful. When I keep saying very, very useful and I get really excited about this, I guess I would be remiss in not telling you that most audiologists don't do these, do not implement them. Unfortunately, if you poll audiologists, they will all say, oh yeah, those I remember learning about those, and those are great, those are very useful. If your next question is, how often do you use them? Well, yeah, not so much. The question why? I don't know. I think most likely people, I know most likely practitioners are going to say time. I just don't have the time. I don't have the time to have them in the waiting room completed because they're checked in and they have a lot of other information to complete, and I can't run behind, and then I don't have the time to go through it. And I'm going to include myself in this. We say that as audiologists. We don't have time. Here's the thing. If we had the patient complete the self-assessment of communication, or the SAC, and if that patient brings someone with them and they complete the SOAC, and it takes them 10 or 15 minutes, both of them, to do that, it could give me valuable information to just provide better care and direct them more quickly, more appropriately. So honestly, on the back end, I would save time, right? Because we would gear them in the right direction. We'd be on the same page. I think that it builds rapport right off the bat, a better rapport. So anyway, I have to tell you, most audiologists will say, oh yeah, self-assessment scales. Are they really implementing them? No. And why? Time. Okay, but unfortunately, sometimes when we put that extra time on the front end to get that information and build rapport and work with our patients in that way, and they feel listened to and heard for their concerns, we give better care and we save time in hearing aid returns and dissatisfied patients and patients who we have to keep reviewing things with because they don't understand. So really, in the end, it's very beneficial. All right, so now we're going to talk about intermediate length and diagnostic self-assessment tools. So these are lengthier reports than the ones that we had looked at, which were screening. Some provide quantified degree of handicap data, while others are designed to establish a profile. So some will give you percentages. Here is a percentage of handicap. Do with that what you want. You could, okay, if we use a self-report or self-assessment that gives you a degree of handicap, we could do pre-AR and post-AR and compare the two, with the hope that the degree of perceived handicap goes down, right? We could do them pre-hearing aid fitting, post-hearing aid fitting, again hoping the degree of perceived handicap decreases. Okay, so that is when we use self-assessment scales that give us a degree or a percentage of handicap, that's how we can apply the data. Or designed to establish a profile, basically like a case history, giving us information, a profile, painting a picture that we can work with from there. Many provide data about situational communication difficulties, right? Wonderful. That way we can, if it's situational, I have more difficulty in noisy environments. I don't go to book club anymore because it's a difficult environment. I don't go golfing anymore because I can't hear the others I'm talking to as we're walking around and we're at a distance. When we have this information, we can fit hearing aids more appropriately, assistive listening devices, Bluetooth technology, okay, when we have that data. And psychosocial effects of hearing impairment. We can counsel our patients, again, within our realm of expertise as audiologists. We can refer them out to appropriate services in the community. We can suggest AR groups where there's discussion about psychosocial effects, and they can see other individuals that have like concerns and issues. Okay, some can be used to obtain information from both patients and significant others, right? Very helpful. Okay, these instruments to varying degrees may be used too. Okay, so intermediate length and diagnostic self-assessment tools, what do we use them for? Help substantiate a patient's hearing complaints not readily apparent from results of conventional audiometric testing. This is a really good one. If we do conventional audiometric testing, pure tone testing, right, to get thresholds, bone conduction testing, your basic speech reception threshold, word discrimination or speech recognition testing, and tympanometry to assess eardrum movement. We can guess at, but we cannot diagnose their degree of difficulty in noise, right? So these are going to help substantiate a person's complaints or their issues, facilitate decisions regarding candidacy for amplification and the benefits, right? So it's going to gear us towards amplification, to different features with hearing aids, to Bluetooth technology. Again, we just talked about it's going to assist in the counseling process, serve as a guide in designing patient-centered treatment programs, serve as a criterion measure for documenting the effects. So it's going to serve as a guide for patient-centered treatment, because if we get this information from person A at 9 o'clock in the morning, when we see person B at 11 o'clock, they may have very different concerns, but maybe a very similar audiogram, right? So we can design patient-centered treatment. Also, the last point, serve as a criterion measure for documenting the effects of rehabilitation efforts. Okay, so we can say, are AR programs working out? Is it useful? If we give them this instrument or tool, we give this to our patients before we do AR sessions, and then again, we can say, is the AR useful, right? Is it warranted? Should we be doing this? Is it a waste of time for us as audiologists? Should we be generating revenue in the clinic instead? Okay, so determining the effects. Okay, so now I'm going to give you just examples of lengthier assessments. The next one is the HHIA. So this is the hearing inventory for adults. How this differs is this is not the screening tool. This is the intermediate length. You can see that there are a lot more questions. Remember the screening, the HHIA and HHIE for the elderly, but -S, the screening tools were much shorter. This is going to go much more in depth. Again, please view these, and I want you to really look at them and say, oh, okay, that interests me. That also, when you're going through these assessments, think about which ones fit your personality, right? And your skill set, and how, if you're going into speech-language pathology at this, or audiology, but I know the majority of you are probably going into speech-language pathology, so think about the different settings that you're in and the kind of patients you want to be talking to, and how you're going to find that certain inventories really fit more of your style than others. And that would be what what you would choose. So this is an example of another one. Again, you don't have to copy and paste the specific assessment into your final project, just an overall of what it is, and you may have to look it up on the internet and get a description, okay, to be able to give me a description. So what is it focusing on? How lengthy is it, right? So this again is the HHIA, but it's much lengthier. Again, S means it's focusing on social questions. E, they're emotion-based. So E, does a hearing problem cause you to be nervous? Does a hearing problem cause you to go shopping less often than you would like, right? So that's going to focus on, are they becoming more isolated? And here's the one for the elderly. So these are the elderly and the adult. They're the full test, or full assessment versus the screening tools. You may choose either one in your final project, the full evaluation or the screening. This one is the Denver Scale of Communication Function. This one is a little bit different. Let's see. This one, I don't have the questions posted, but this one is going to focus on, this is actually the profile form of how we would rank it: family, self, social vocation, and communication. And then we have pre-service administration. So we would give it once before, either they're fit with hearing aids or they go through oral rehab classes, and post. I can tell you this one is used less because of it is a more complicated assessment form. This is actually the modified scale. So this is the quantified Denver scale. So in this, this differs from the HHIE also, that they're ranking it different versus yes, no, and sometimes it goes from strongly disagree to strongly agree. So that gives an individual maybe a broader range than yes, no, and sometimes. So again, I really want you to look at these because you're going to need to explain to me why you chose one of the other. And maybe again, some may fit your style. If you were asking the questions, if you were working with individuals or family members, some, I'm assuming, would fit your style better than others. So this one, let's glance at a couple questions. The members of my family are annoyed with my hearing loss, and then they would rank this. I am not an outgoing person because I have a hearing loss. People sometimes avoid me because of my hearing loss. So this is really interesting. This ranks of, I feel this in myself, and other people perceive me as such and such. Okay, so really interestingly phrased questions. This is a little different also. This is the McCarthy-Alpiner Scale of Hearing Handicap. And this one, people are asked to check always, usually, sometimes, rarely, never. Let's look at some of these questions. I get annoyed when people do not speak loud enough for me to hear them. I get upset. I feel like I am isolated. I feel negative. My hearing loss has. I am afraid that people will not like me if they find out I have a hearing loss. So again, it's both I feel and then I see. I'm assuming others perceive me in such and such a way. Okay, so again, this is going to be a profile. Honestly, I can't remember if we would really score these or just look at, we could look at pre and post rehabilitation, or just look at it as a profile like we would a case history. Look it over and say, oh, okay, there's a kind of a trend of usually, always versus never, or sometime, rarely. Okay. This is continued, so you can see these are getting very lengthy, which is also a consideration, depending on the population you're working with. Visual issues, cognitive issues, dexterity issues. Are they able to sit and fill this lengthy form out? Okay. Here's a few more diagnostic self-assessment tools. So this is more than just a profile. We have the HPI and the CPHI, the Hearing Performance Inventory and Communication Profile for the Hearing Impaired. The purpose of diagnostic self-instruments. Diagnostic self-report scales are lengthy and, as such, are able to provide detailed rehabilitation assessment for performance in everyday communication situations. So it's really going into a lot of detail. Their analysis shows that, one, the development of their analysis allows the development of patient-specific rehabilitation programs, okay, which we've talked about, and two, criteria to monitor the effectiveness of treatment. We say treatment discharge. That's a funny term, because there's really no discharge. We don't really discharge our hearing impaired patients in audiology. I know with speech language pathology, sometimes you accomplish your goals, perhaps with children and articulation, and maybe you'll follow up after or if other problems arise, but you essentially discharge from therapy. In audiology, we don't, if it's a sensory neural hearing loss or a mixed hearing loss or retrocochlear hearing, we really don't discharge patients because there's really ongoing monitoring, right? And if it's a fluctuating hearing loss or a progressive hearing loss, which sensory neural hearing losses tend to be, we're monitoring and we need to change programming or add other devices or Bluetooth. So treatment discharge isn't really applicable to audiology. Anyway, the length of the profiles require a significant time period for completion. Often it's best to ask the patient to complete the profiles at home and analyze the results later. So sometimes this can be done. I found the easiest way to do this is when a patient schedules an appointment, then their information is mailed or emailed to them, or we can ask them to pull it off of a website, to complete it, and to bring it in with them, or email it back. So then we would have it, and that would save some time. These are going to be very lengthy. Okay, here we go, 158 item profile. Okay, so to be completely honest with my audiology peers and colleagues, if we weren't doing the short ones, not a lot of people are doing the lengthy ones, but they're out there and can be, and when utilized are fantastic. So the Hearing Performance Inventory is 150 items of hearing performance in everyday communication situations, and inventory items are divided into 5 categories. And it's just, excuse me, categories of different environments. So patients are presented with everyday situations and asked to judge their listening performance according to a rating of 1 to 5. There is a shortened version of this that's 90 items that could take about 20 minutes. And you can generate an overall percentage. So again, this one can be used as a profile or a percentage to get pre and post rehabilitation, pre and post hearing aid fitting. Okay. The next one, excuse me, the next one, the CPHI, or the Communication Profile for the Hearing Impaired, is 154 items. So again, very lengthy. It's a comprehensive instrument, yields a 25 scale score and 3 important ratings of 4 general areas. Again, it's looking at overall communication environments and perceived level of difficulty. And if you wanted to look, oh, okay, yeah, here's some sample items. So sample items are, you're at a social gathering with music or other noise in the background, and they're asked to rank out the level of difficulty. You're at a work or a place of business and someone is talking to you from the other from the other room. So those are kind of sample questions, and you could find the full the full assessment online. And then there's different environments. Communicating with others is an important communication environment, the physical environments of listening, and the interpersonal. So that's what this is going to look at. I have to talk with others when there's a lot of background noise. Others think I'm ignoring them. So we're going to get a whole lot of different environments, or a whole lot of different aspects, the perceived attitudes of others, different environments, different needs and their level of difficulty in those environments. So very, very detailed. Again, we have to think too about what populations this is appropriate to, right? Clearly, these self-assessment scores would not be appropriate to give to parents and caregivers of toddler groups, right? Some of these really lengthy evaluations may be difficult for seniors or elderly population, so we have to consider that also. Okay, and then there's another category, and see, personal adjustment. So I gave you all kinds of examples. Okay, these we've already talked about. Remember, these are specific to hearing aid use. So we talked about hearing aid use, benefit, and satisfaction. The happy, actually this is a shortened version of the AFAB, the cozy, oh yeah, and the AFAB. This gives you some examples. Again, this is about hearing aid performance. Let's see, the benefit provided by hearing aids is analyzed separately in 4 types of listening situations: noisy situations, quiet, situations with reduced signal information, situations with non-speech or reduced speech stimuli. So with this, we can rank and do a before and after, before fit and after, or comparing 2 different types of hearing aids. But again, this one is pretty lengthy. 64-item questionnaire is pretty lengthy for some individuals. And then this gives the example. To answer each question, check the phrase that best describes how your hearing aid helps you in these situations. So very helpful. Also, we can give this, actually this would be after they're fit with hearing aids, not pre and post, but after. Actually, we could give this also pre and post based on the questions. You are sitting alone at home watching the TV. Oh no, I'm sorry. So this would be after their hearing aids. So this would show a profile really of how they're doing, maybe to review it and highlight areas that still are a concern, and those could be worked on with programming changes or programming the settings of the hearing aid, Bluetooth technology, maybe focused AR, specifically communication strategies or speech reading. We could look at this if we're comparing maybe an individual's old analog hearing aids to newer digital technology, if we're comparing 2 different manufacturers. So that would be some of the uses of the happy. Again, I think I scanned in a bunch of it. Cozy. Of the ones used by audiologists, this one is probably the most popular. It's very quick. That's probably why. The Cozy, or the Client-Oriented Scale of Improvement, is an open-ended self-report for use with hearing individuals or hearing aid users. The questionnaire is administered in an interview or counseling format that allows the patient to describe and rank communicative needs and difficulties. The benefit provided by hearing aids in this situation is then assessed after fitting. Oh, I'm sorry. This says see PDF document and course content. That was from a previous class I taught, and I don't have it listed. If you're interested in looking at the specifics, you could look at this online. But the Cozy is really just one short form to list perhaps 5 areas of most difficulty and then rank how pre and post. So it's really to look at, okay, what are our top concerns? Where's our focus going to be with hearing aid fittings? Again, and you see too, this is really helping build a rapport with our patient, their family members. They're part of the process instead of just testing them and putting hearing aids on them. It feels like, okay, what are our objectives here? What are our goals? The profile of hearing aid benefit. This is a questionnaire to estimate the portion of time that certain situations present communication difficulties with and without hearing aids. So this is looking at 4 different types of questions: ease of communication, communication in noisy situations, communication in reverberant reverberant situations, so like poor acoustics and the sound is bouncing off the wall, and tolerance to loud sounds. And this is the long version, and then we're going to see the abbreviated version. So the cozy and this abbreviated version, the AFAB, are probably are the most common utilized by audiologists. Okay, and those two are really, again, assessing. We can assess pre and post. Oftentimes you'll have individuals that say, oh, I've had these analog hearing aids for 15 years and I don't know if what you're telling me is going to be any better. Well, we can compare the two then. We can do a profile based on them using the analog hearing aids and then use the digital and compare the two. Or again, like I said, compare pre and post fitting, or compare different types of technology. Okay, so again, very, very useful. So, I thought that was a cute comment. You've returned the hearing aids 15 times now. The note on the file says you're the problem, right? Not the hearing aids. So remember, a requirement of the final project is to go through these, or the hearing aid, the self-assessment we've talked about. You can look at other self-assessment scales related to hearing impaired individuals online. I've discussed a large group of the most known ones, but not every single one out there. So please feel free, if none of these strike you, to look online for self-assessment tools to assess hearing impairment or a hearing disability or hearing handicap. So if you want to utilize one or describe one that I haven't discussed here, absolutely, that's fantastic. And again, pick them based on how they're going to be applicable to the population you choose, and why, and your style, your own personal style, and what about them you think works or you find interesting. Okay, as always, let me know if you have any questions and concerns.